Super excited to welcome a familiar face back to the podcast. Welcome back, Dr. Meherg, General Surgeon here at Coleman Regional. Thank you so much for joining me.
Yeah, absolutely.
Yeah, and so we had you on the podcast before, talked a little bit more about your background on that episode,
Right.
and some other stuff. So if anyone wants to listen and learn a little bit more about you, they can visit that episode. But today we're talking primarily about the gallbladder surgery. Talk a little bit just to begin with the what are some of the common complications and conditions that lead to a gallbladder surgery?
Okay.
And then when do these conditions typically arise in the patients?
Right. So there are a couple different things that I mostly see. Obviously, there's kind of the outliers, but the main things that we're taking care of with gallbladder surgery are either gallbladder dysfunction, meaning that the squeeze, or it's also called biliary dyskinesia, but the squeezing effect of your gallbladder is not necessarily working appropriately. That's one thing. Another big thing is gallstones. So gallstones don't necessarily mean that you need your gallbladder out, but they can become symptomatic. The way I always describe it is that they can basically clog up or put like gravel in a drain. And so when it's trying to squeeze, it causes a back pressure and causes some pain. So you can have that. More acutely, as far as ER is concerned and such, we usually see cholecystitis, which is actually infection. That can be due to stones, or it cannot be due to stones. And the infection is due to the cystic duct, which is draining the gallbladder, being occluded. When that's occluded, once again, it's causing a back pressure, and then that can cause wall inflammation. And so just like any other infectious process, you can have fever and chills and such. And people usually typically have a lot of right upper quadrant abdominal pain when they're having that, and that's usually pretty quickly onset. And so people end up in the ER, get scanned, and then they call us about the acute cholecystitis. But we see a lot of people outpatient too for those other things where it's still functioning, but they're having symptoms. And oftentimes we'll see that these symptoms start once and then they may not happen for another 2 years. And then all of a sudden it may happen again, and then it happens again, and it keeps on getting a little bit more frequent. And so when it's starting to change your lifestyle, because what you're talking about, like, I guess, and you probably will hit on these a little bit later, some of the symptoms would be like nausea and vomiting, the pain. Usually this is after people are eating, especially fattier meals. So pizza is always one that people say they just ate pizza, and then this happens. It starts happening more frequently. And so if you just have an episode, usually that's about 4 hours of discomfort, which sounds like a lot still, but then it kind of goes away. So people kind of just write it off like, oh, that just didn't sit
I should
well.
probably just not eat that
Right.
as often or whatever.
Right. And so that's kind of what people do. And just like everybody else, they're just like, oh, well, it got better, so we're fine. Well, sometimes that happens and it doesn't stop. Or it just happens more and more frequently. So that's when we talk about getting your gallbladder out. And obviously that's surgically.
Yeah, and so I guess, do you see it often as patients come in with symptoms that could be gallbladder, but not thinking it is their gallbladder, and then you're having to, after testing, you're like, okay, well, I think it is your gallbladder,
Right,
is causing these symptoms.
right. So I always say that not everybody reads the book. So you have like your textbook patients who come in and they're always like what I just described, nausea and vomiting after eating fatty meals, right upper quadrant abdominal pain, abdominal bloating. Those are like textbook. But also I always say to my patients that your stomach and your gallbladder are actually very close. So sometimes like ulcer disease and such can be kind of similar in their symptoms. So oftentimes we'll kind of go through some of their other symptoms, like their full symptomology, and decide, well, is it that we do still think it's gallbladder? And then there's different testing that we can do, like different imaging modalities. The most specific is usually ultrasound, but we can also do CT scans as well.
And so you alluded to it a little bit earlier, but not every case causes to actually have surgery.
Right.
Talk a little bit about some of those. Maybe if a patient comes in early, is that typically you're able to treat it a different way, or does it just does it not necessarily depend on the timing of them coming in? Just what that patient is,
right?
And kind of maybe their lifestyle that they're living.
So I think that I do get these sometimes, and what we call it more is like an incidental finding. So you go to the ER because you're having some issues, and they happen to scan you, and they say, oh, and you have gallstones.
Yeah.
Well, that's not your problem. You actually have acute appendicitis, or you actually have a bowel obstruction. You have something else going on. But hey, by the way, you also have gallstones. So people come to me and they're like, what do I do about that? And I'm like, so I'll go through their symptoms and see, did you ever have symptoms of having gallstones, or was it just something they found? Oftentimes, like especially a finding like that, people don't even have any symptoms. And so it's kind of one of those things that I'm like, hey, if you start noticing that you're having this. then absolutely come back and see me.
Yeah.
Because we don't want it to be where it actually becomes something that you end up in the ER. We would rather do it a little bit more planned anytime, of course, so that way you can figure out for work situation and all of that. So
Yeah.
a little bit more planned is always better.
Yeah. And so as far as like having gallbladder surgery or finding out you have gallstones, is there a typical age range that you see most common coming in, or can it be, people kids in middle school or high school to, 60, 70, 80-year old?
So, there's certain things and certain age characteristics and certain body characteristics that are going to make you more prone to this. So, being overweight, obviously, America has an issue with obesity, so that's also why we have a bariatric program here, and so that can cause you to have gallbladder symptoms. Also, rapid weight loss. So, especially with folks that are doing some of the new GLP drugs, they're great. They definitely help people lose a lot of weight, but you're having this rapid weight loss, and a lot of people are coming in because they're having biliary dysfunction then. And so you can also have pancreatitis and other issues with those drugs, but that's one thing that we're noticing. Another thing is diabetics. People who, I get a lot of this, Dr. Massengill, I feel like passes around patients sometimes because I get a lot of postpartum patients, or they start noticing that they're having symptoms while they're actually pregnant, and it's the estrogen and the hormones that is causing some dysfunction. But after they have the baby, it still continues to go on. Well, now they're out of their pregnancy, so it's obviously a more ideal time to operate. So we get some of that, and just due to like the hormones and everything. So yeah.
And so looking at the actual surgery as like the surgery procedure, talk a little bit about how robotic surgery has advanced kind of on the gallbladder issues, and what benefits has it compared to maybe the more traditional approach?
Right. So obviously minimally invasive, whether that's laparoscopic or robotic, has obviously transformed surgery completely. Doing an open gallbladder, which in training we do some just because of different reasons, more of like malignancy issues and things like that. Sometimes you have to do open, but that's a very large incision. That's a subcostal incision across. So doing the small poke holes is great. And that's kind of how I describe it, as like the poke holes. Obviously, there's some people that would never be able to have that, but that's pretty rare. For the most part, most people can do have minimally invasive surgery, especially for their gallbladder. As far as the comparison between laparoscopic and robotic, so I prefer robotic. So as my partner, Dr. Thompson, we both do pretty much, actually all of our gallbladders robotic. I don't know why I said pretty much, all of them robotic. And the reason being is that we just have so much more control of the situation. It's the ability to visualize the structure. So I want to be safe and find like the critical view of safety to make sure that I'm getting just your gallbladder out and not injuring anything else. Laparoscopic surgery, yes, you can still achieve those things. Those things were, the critical view of safety was developed by those people who were doing laparoscopic surgery. But that being said, it's just a better overall visualization of everything. So I feel like I have a little bit more control over it. The other thing that really makes it great is that we can get something called ICG, and it also helps. It does a firefly technology and helps light up the ducts so that you can say, yes, this is a duct, this is not the artery. You can really just visualize, and so it gives you like, it's an additional tool that it's not that they don't have that in laparoscopic surgery, but it's much more convenient, I would say, with using the robotic platform. So I think that overall, just the ability to use the robot for gallbladder surgery has made it so it cut down the time. And I always say laparoscopic surgery is somewhat like doing chopsticks anyways. So if you actually can feel like you're moving your hands versus doing kind of like a chopstick situation, in my opinion, I think it definitely helps with safety and helps with the healing is still there, and it's comparable as far as healing to laparoscopic surgery.
And then I assume with that, with the shorter amount of time that it takes to actually do the surgery, you can perform and give relief to more patients on a daily basis.
Yes, and then also the patient doesn't have to be under anesthesia as long either. So if you get the surgery done faster, and you're still able to do it, you're able to do it faster, but still be efficient and making sure that you have those views, and that you're doing it safely, then I think that waking the patient up, getting them over to the recovery, that's the best thing you can do for the patient.
Yeah. And so talk a little bit about that patient journey as far as, they come in, they have the surgery, you perform it robotically. What does that post-surgery look like for the patient? And then maybe what are some restrictions dietary-wise or kind of lifestyle-wise that the patient might be experiencing post-gallbladder surgery?
Right. So typically, especially elective, obviously, this is you come in for, it's a 1-day surgery. You come in the morning, they get you all set up. You have the surgery, you go to recovery, and then you leave later that day.
Wow.
And even if it's an emergency surgery, sometimes you can leave later that day. It just kind of depends if you have on other factors. So afterwards, you just had surgery, even though, and I always say, even though small poke holes, this used to be a major surgery as far as it seemed more major because there was a huge incision. So it's still a big surgery. You have to recover from that part. So you have pain medicine, you have nausea medicine that's sent home with you just to kind of help you recover from that. So you're going to be sore. The gas that we fill you up with to do minimally invasive surgery oftentimes causes some shoulder pain as well. So trying to get up and move is actually good for it. It helps work that out. As far as diet, I tell people they really can eat whatever kind of sounds good. I usually say start bland and then work your way up. One of the biggest complaints after gallbladder surgery is actually diarrhea, especially right after you have your gallbladder taken out. There's a couple different reasons for that, but one thing to just think about is like certain things may make it worse.
Yeah.
Meaning, like if you all of a sudden have a huge fatty meal, it actually may make you have diarrhea. And so, especially in the first 6 weeks, I kind of tell people just take a little easy. Just if you used to eat certain things, it may upset your stomach, but it should start to normalize some. So I think part of it is that your body's getting used to not having your gallbladder, but other parts of it is that people learn what does upset their stomach and what doesn't. So that's that. Usually they can shower. No, usually we don't want you to like soak in a tub or a lake. I don't want you to go to Smith Lake this weekend if you just had gallbladder surgery because you have incisions and I want those to heal. No driving while you're on pain medication. So those are some limitations. And then all of these, even though they're small incisions, they can get bigger, especially if you lift too soon. So no lifting greater than 20 pounds for 2 weeks is typically like our kind of standard cutoff.
Yeah. And so, I mean, it is such it's incredible to see that process of having the surgery being such, I mean, it is like, it used to be like a big surgery. I mean, like, especially like in the complexity of having that incision and then going in. And then I think I even remember people having it and being in for a long period of time and like not being able to go home the same day.
Right. No, a lot of times actually, when I have seen it, people are using like PCAs, which are like pain control pumps in the hospital and staying for several days afterwards, just because it's splitting open your muscle layers and it's painful surgery.
Yeah. And so as we kind of wrap up the conversation, what are some ways that the people that are listening can advocate for themselves with their healthcare providers talking about gallbladder issues and potentially going into and having a gallbladder surgery?
Yeah. So I think just talking to your like primary care or whoever you're going to and saying, I think I am having some pain and it kind of keeps on happening, especially if it's happening more frequently. Some nausea, some vomiting, my stomach just stays bloated. Usually primary care doctors will start with like an ultrasound and kind of just see, okay, is there some type of dysfunction? There's also something called a HIDA scan that can show how well your gallbladder is squeezing, like the percentage even.
Wow.
So if your gallbladder is not squeezing enough, that could also be causing you to have some dysfunction. So I think just advocating like, hey, I am having symptoms. That's not just some random thing that is happening. This is happening more and more frequently. We need to get this checked out. And then typically if they see something, they'll send them over to me. So that way I can kind of review the imaging and see if it's appropriate to get your gallbladder out.
Awesome. Well, I appreciate you being here again today. Back on the podcast for the second time. We'll be sure to have everything in the episode notes, links, stuff that we've talked about. So if anyone has any questions, there'll be resources there. But I appreciate you being here.
Absolutely. Thank you.